Hello and welcome to another Be Well with MS episode about the science and insights navigating MS and pregnancy. I'm your host, Dr. Agnes Trokena. Today we have a distinguished guest with me, an exceptional expert in the field of neuroimmunology, Associate Professor Vilija Jokubaitis, who is a leading groundbreaking research at Monash University in Melbourne, Australia. Vilija and I share a common background. We are both proud Lithuanians. So the way I pronounced her surname is the correct way. It's Jokubaitis, not Jokubaitis. So welcome to this episode, Vilija.
Thank you very much, Agnes.
Associate Professor Jokubaitis heads the neuroimmunology, genomics and prognostic group. She's not a neurologist. She's demonstrating her exceptional skill set that spans the genomics, molecular and cellular biology, bioinformatics, clinical outcome research, and biostatistics. She's internationally recognized for her pioneering work in multiple sclerosis prognostics, women's health, and genomics. Her contributions have been integrated into international clinical management guidelines and consensus statements, shaping patient management strategies. Additionally, she holds leadership roles, serving as the chair of the International MS Clinical Outcome Registry, MS-BASE. This is the most famous, the largest MS base in the world, and ANSGene, the Australia-New Zealand MS Genetics Consortium. She is also a founding executive member of the International Women in MS Network, which is called IWIMS. So today, our aim is to delve into the critical topic of multiple sclerosis and pregnancy, tapping into her vast expertise to provide valuable insights and guidance on managing MS before, during, and after pregnancy. So let's get started. I would like to set the scene here, and I recently we both attended with Vilija, and we were so excited seeing and meeting each other. We spent a great time in Milan. This is where the ECTRIMS conference been held, and we found from one of the sessions that it's been presented by one of the Spanish team around the survey of misinformation living with MS and being or becoming pregnant or planning the family. And what was exciting and in a way slightly concerning to learn that women who are living with multiple sclerosis, around 50% that state that they receive misinformation, and that's really something that I'm worried, and I would like to enhance the understanding and boost that misinformation and equip people and women with the appropriate information that they could plan families in a very informed way, that without any worries and fears that may be associated with this family planning issue. And also, a lot of women think that disease-modifying therapy can affect the fertility, which is something that is not true. Also, there is a misinformation about the worsening of the childbirth, which is not true. Also, there are some various different aspects towards the harmful effects of the disease-modifying therapy on the fetus, which is, again, something that we need to discuss in more detail. So this is the time, I think, to talk with Vilija, who's an expert in the science, and she's done loads of research and published a few projects around the pregnancy and the disease-modifying therapies, and she has got an extensive experience in running the projects and looking at the women's health in general. So I would like to bring Vilija to this episode and talk through about what is the perception of the MS and pregnancy that I'm pretty sure it evolved over the time. Any insights that you could bring into this episode based on your recent research and MS treatment during the pregnancy?
Absolutely. It's a very, I guess, broad topic, but maybe the best way to approach it is to go back to, I suppose, the late 1990s. And I know that sometimes it doesn't seem so long ago, and yet in the research space, that's, almost ancient history now. So I suppose the key thing that happened in the late 1990s was that there was a seminal paper that was published by Professor Christian Contreveux from France. But prior to this publication in 1998, it was perceived that pregnancy might, in fact, worsen disease outcomes for women with multiple sclerosis. And so a lot of women were actually discouraged from having children and having pregnancies because of this fear that being pregnant might interfere with their immune system and exacerbate it and make their MS worse, both during pregnancy and in the long term. And so his study was really groundbreaking at the time, because what he showed was that during pregnancy, relapse rates actually diminished very significantly. And relapse rates diminished with each trimester, being the lowest in the third trimester of pregnancy. Although he also demonstrated that relapse rates then rebounded after delivery. But this was really crucial knowledge, because it was the first time that we had some scientific evidence to suggest that pregnancy was actually potentially beneficial for women with MS, at least during the pregnant time, because their disease activity went into remission, more or less. So that was groundbreaking. But a lot has happened in the time since then. And so although we know that pregnancy is not harmful for women during the pregnant period, a lot of things have happened. So, for example, when Professor Contreveux's study was published, there really weren't many disease-modifying therapies available for multiple sclerosis. So those findings were based on women with very mild disease activity who perhaps were more confident in having a pregnancy. Since then, we've seen this incredible evolution of disease-modifying therapies and their availability over the last 20 years or so. And so today we have 16 different disease-modifying therapies available for the treatment of multiple sclerosis. And that's really complicated, decisions that women need to make and advice that clinicians need to give their patients when they're considering having a child. So that's, I guess, one of the key components. So over the time, there's been a number of research studies done, including research by my team. And what we've shown is that at least the pattern of disease remission in pregnancy remains. So as women with more severe MS are more likely to have pregnancies because their disease is better controlled with these new disease-modifying therapies that are available, we've still shown those same trends over time, that showing that disease activity still remits during pregnancy, but that there is a rebound of disease activity after women deliver their babies. In terms of what we've discovered over the last decades as well, in terms of the impact of pregnancy on longer term disease outcomes for women with multiple sclerosis, that's been a lot more controversial. So I think that everyone in the scientific and clinical fields would all agree that disease remits during pregnancy, but does it actually impact disease outcomes in the longer term? So some of my research published back in 2016 actually demonstrated that women who had pregnancies accumulated less disability over a 10-year time period than women who did not have pregnancies. And the effect was actually 4 times greater than the low efficacy disease-modifying therapies interferon beta and gluturamine acetate, also known as Copaxone. And that was quite an incredible finding. But there have been other studies that have been published subsequent to that, suggesting that perhaps our research was biased, that perhaps, again, it was women with milder disease that were more likely to have pregnancies, and that we weren't taking into account women with more active disease, and perhaps outcomes were different for them. There's also, I guess, when we try to account for the impact of pregnancy on longer term outcomes in women with MS, it is really hard to overcome this bias. Is it just that women whose disease is more mild are those having pregnancies, and therefore we're seeing better outcomes for them? And how do we actually get around teasing that out? And how do we actually study women with more active disease? And so I think over those last number of years as well, since that paper was published, we've actually developed a lot more advanced statistical methods to answer these questions. And so there have been a number of studies that have been published subsequent to ours that suggest that pregnancy actually has no impact on the disease course. It's not beneficial, but nor is it harmful. And so a lot of studies, or not a lot, but a number of studies have been putting this forward, and those studies have come from France, they've come from Spain. But I don't think that it's a one-size-fits-all answer. I think that just like MS is a very heterogeneous disease and outcomes are very variable amongst women, and some individuals with MS react better to some disease-modifying therapies than others. I always had this idea that perhaps pregnancy is also something like this, that perhaps pregnancy doesn't have the same impact for all women with multiple sclerosis. And perhaps there's a time when it's maybe better to have a pregnancy, maybe earlier in the disease when you're younger. And so that's something that we've explored recently and that we presented at the most recent ECTRIMS conference in Milan. And whilst this paper is now submitted for review, it's not published yet. So again, we'll have to wait and see what our colleagues think. What our research findings suggest is that there is actually a window of opportunity where women can benefit from pregnancy in terms of reducing their long-term disability accumulation. And that's in women who are 30 years old or younger and who have had MS for less than 5 years. After that, again, there's no harm of pregnancy on the long-term outcomes, but also we didn't see any obvious benefit either. So as I said, it's a little bit, it's new, it's perhaps going to be a little bit controversial, we'll see. But overall, I think, one of the greatest misconceptions that we do need to ensure that women are aware of is that having a baby will not harm a woman's long-term MS outcomes.
That's wonderful. Vilija, I'm just going to just quickly summarize and link into the clinical practices, what we see in our clinics. So we always try to educate our people, women with MS, that pregnancy is not harmful. Your babies are going to be born as healthy as a normal population for women who don't have MS. That's really important to know that. And we always say to women with MS that have your families and as soon as possible, because as you can learn from Vilija's research, that the younger you are, the less you are into the disease duration, the better the outcome, and it may benefit you being pregnant. And I have a real world experience, in particular one of the patients that crossed my mind just now, that she's having her third pregnancy, because during the pregnancy she feels so good. All the function, all the symptoms improve, and she's just looking for a chance to be pregnant. So really, we always say to our women that we have so many babies and they are all fit and healthy. So there is no fear to have families and extend it. MS is not a genetic condition in a way. It doesn't cause fetus anomalies having MS. And it's super important to plan that in as soon as possible. Once you got diagnosed, and if you were having dreams to have family, please do go and make babies. It's normal. It's absolutely okay. I guess some concerns that we need to take into account if we are thinking about the relapses and activity. Postpartum is the most vulnerable period of time, as Vilija mentioned, that within 3 months is something that we see people relapsing. But there are some certain circumstances that increases the chance of having a relapse. For example, if there is a withdrawal from the previous high efficacy drugs such as natalizumab or fingolimod, for example, and if there were relapses throughout the pregnancy or pre-pregnancy activity, such as relapses or new MRI scan changes, that would set the scene that there is a chance or a risk that that you may experience more relapses after you gave it birth 3 months later. And the way we look at you these days, we really look at how can we implement strategies that we could prevent you from not having a relapse 3 months later after postpartum. And there are some preconception in multiple sclerosis clinics. I know a few places in Britain. So one is Queen Square Hospital, and the other place is at Sheffield Hospital. I'm sure that there are some researchers and neurologists that are thinking to set one of the clinics preconception, because it really improves the outcomes and reduces the disease activity, because it requires a strategic planning. So if we expose patient with a disease-modifying therapy and stabilize the highly active MS. I mean, a few relapses in a very short period of time with changes on MRI scan, we class that as a highly active MS, and we try in these circumstances and situations to stabilize the disease activity first before women start conceiving and becoming pregnant. Because the rationale here is that we really would like you to be fit and healthy mother to look after the newborn. And we have various different discussions in our clinics to how can we best achieve that. And some women choose certain drugs that are reconstitution irreversible therapy, like cladribine or lemtuzumab, for example, which you're getting 2 cycles, and then a year later you may start conceiving for a baby, and then by this time we stabilize your condition. There are also therapies that are safely used in MS before and during the pregnancy for highly active MS, which involves interferons, injectables, natalizumab, and we control the process throughout the pregnancy and immediately after. So let's delve into this landscape of the treatments, Vilija, exploring the safety of disease-modifying therapies. I just mentioned a few of them. What are the considerations for the disease-modifying therapies? Are there any harm on potential harm of fetus or not? And what are the medicine that we should be more concerned or less concerned?
Yeah, that's a really great question. And I think, you articulated it beautifully in terms of what the potential risks are for disease activity, both during pregnancy and after. And I just really wanted to highlight 2 things. One was that we published a study just a couple of years ago. And here we actually showed that there are still 12% of pregnancies that experience relapses in the pregnancy itself. And in the 3 months after pregnancy, the percentage of women with relapse is about 14%. But I think we're able to drop that down now with better knowledge as to how to use various disease-modifying therapies. And the other key thing that I think that people don't really talk about, and again is something that we need to be really aware of, is for those women that have a termination for whatever reason, or who have a spontaneous miscarriage, the risk of having a post-pregnancy relapse is about 10% in those women as well. So I think it's just really something to be aware of, that, you don't need to go to full term to still be at risk of a post-pregnancy relapse. But speaking about, the different therapies and which ones are safe to use and what are the maternal risks and what are the fetal risks, these are really important questions. And as you said, there are some therapies that are highly effective that, in effect, they sequester the immune system and prevent it from moving into the brain and into the central nervous system. So some of these therapies, fingolimod and natalizumab, it's really important to know about the safety around these drugs. So fingolimod, for example, we found out a few years ago that it's actually not safe to use in pregnancy because there's an increased risk of congenital abnormalities. And these are cardiac abnormalities, but also musculoskeletal and kidney abnormalities. So women who are using fingolimod and want to become pregnant need to withdraw from these therapies for several months prior to trying to conceive for that exact reason. But because fingolimod holds immune cells within the lymph nodes, once women stop using it, those immune cells are released, and that increases the risk of having a relapse rebound. And so it's really important to have a strategy before you try to conceive to determine which medication to switch to that's safe to use in pregnancy for you and for your fetus, to make sure that your disease activity isn't exacerbated due to that withdrawal. And one of these medications that's been shown to be safe is actually natalizumab or Tysabri. And so that's a therapy that we now know is safe to use in pregnancy. And it's safe to use up until about the 32nd week of pregnancy. Quite often, what might happen is that clinicians might change the dosing schedule for natalizumab. So normally it's an infusion that women receive once every 4 weeks. But during the latter stages of pregnancy, that might get extended to every 6 weeks, which has been shown to still be very safe and effective. But the reason why women need to stop using natalizumab by about the 32nd week is because there is a risk to the fetus if it's continued to be used beyond that time point. And so that's because natalizumab is a monoclonal antibody, and it's a very large molecule, but by about the 2nd or 3rd trimester, the placenta becomes permeable to these large molecules, which means that the natalizumab can actually transfer across the placenta into the fetus. Now, the risk that comes with that beyond the 32nd week is of a medical condition called thrombocytopenia. What that means in normal language, for anyone who's not familiar with clinical terms, is that your baby is at risk of having fewer platelets. And platelets are the blood cells that are really important for blood clotting, so that if you have a cut, for example, that your body is able to heal that cut with a clot. And so the risk here is that if there was a delivery complication, for example, and the baby has lower platelets, then maybe there's an increased risk of injury to the fetus during delivery. And so that's why it's recommended that natalizumab is stopped being used by about the 32nd week. However, the great thing about these monoclonal antibodies, and there are a number of MS therapies that are monoclonal antibodies, is that, again, because they're very large molecules, they don't get into the breast milk, into mature breast milk in high quantities. So it's actually safe to restart the use of natalizumab within days of delivery if, your obstetric and neurological teams can manage to organise that for you. So I suppose they're just some of the considerations, but of course, different therapies have different safety considerations for the fetus.
What about anti-CD20 therapies, which is classed as ocrelizumab or Kesimpta? Have we got any information about the potential risks and benefits being on the anti-CD20? I remember attending one of the lectures at ECTRIMS, and there was a great data presented that ocrelizumab really diminishes the activity if women are exposed by anti-CD20 before the pregnancy. The rate of the relapses during the pregnancy and immediately after postpartum is really significantly lower, which is amazing finding. What is your view on this, Vilija?
That's actually work from our research team.
Here we go.
Yeah, so we examined 88 pregnancies exposed to ocrelizumab that were recorded in the MS-based registry, which is the largest clinical outcomes registry globally, and of which I'm the chair of the scientific leadership group. And so what we were really interested in is to understand exactly that. If women are exposed to these anti-CD20 monoclonal antibodies, in our case, it was exclusively ocrelizumab. We didn't look at Kesimpta because really that's a very new drug. Kesimpta is delivered as an injection as opposed to an infusion. So we still don't have terribly much information about that. Not many women have conceived yet, or at least not enough for us to do any scientific studies on. But exactly as you said, women who had well-controlled disease activity that had been using ocrelizumab prior to their pregnancy, we didn't find any relapses during the pregnancy period in the women that we analysed, and we only recorded 3 relapses in the postpartum period for those women. of which 2 of those relapses occurred prior to them restarting therapy. So it looks like these anti-CD20 antibodies have a really long-lasting immunosuppressive effect, which can see women through their pregnancy very comfortably without any disease activity reactivation. My one caution is that we looked at clinical relapses. We didn't have any MRI information, so we can't comment about whether or not there were any silent lesions, for example. But the science looks good. And I think, there have been concerns previously about when and how to use these antibodies. The biggest concern with ocrelizumab is that if women have an accidental exposure during pregnancy to this drug, it can actually also cause B-cell depletion in their infant. And of course, that's not something that we want. And so there's been a lot of conversations about how and when to use these therapies appropriately. And we actually co-authored a consensus document on this. It was published in the Lancet Neurology just earlier this year. So experts on pregnancy from around the world, led by Professor Kirsten Hellwig in Germany. And even though it's, I suppose, off-label instructions, so Roche, who manufacture ocrelizumab, would say that women should wait 6 months after their last infusion to become pregnant. I think with real-world evidence coming through, more and more clinicians are comfortable using a conservative approach of using 3 months after their last infusion. And in fact, some clinicians are now also suggesting that it's safe to become pregnant in the next menstrual cycle after the last infusion. So the time window within which it's being now recommended that it's likely to be safe to conceive is quite soon afterwards. And again, that's because of our scientific understanding of the dynamics of when these therapies can actually cross the placenta and have impacts on the fetus. So yeah, that's the latest in terms of what we understand in relation to the use of that drug. So that's also a very good option for women planning pregnancy.
Wonderful. We have so many powerful tools, and I have to just want to be an advocate for patients. These pregnancies happen spontaneously sometimes without even planning. So, so it's difficult to stick to the protocol and policies that, 6 months you should, you stop medicine, then you start conceiving. Life is life, for women, and things happen. So we have to be pragmatic and realistic. And we have so many women who become pregnant whilst they having anti-CD20 or ocrelizumab or Kesimpta or ofatumumab medicine. Things happen, and I think we've seen quite great results from the clinical perspective, women being in remission. So I think it's a wonderful overview of all the possibilities, bridging therapies such as Tysabri. The extending period of time of the infusion is sort of the 4 weekly going to 6 weekly throughout the pregnancy is a good approach in managing the reduction of the disease activity and also minimizing the risk of the PML and JC virus reactivation. I think the general rule here that if you are planning to have babies in the near future, or if you are already on the medicine in a format of the tablet form, usually, broadly speaking, we have fingolimod, we have teriflunomide, we have new medicines such as Ponvory, similar sort of to fingolimod, action mode SB1 receptor. So it's something that to bear in mind when you choose before you start at the very early stage of your disease and when you are diagnosed with this condition. Family is an essential requirement to discuss it every single MS clinic. And somehow I think we rely a lot on our MS nurses to talk about and provide some counseling. But I think if we run into sort of MDT clinic with obstetrician, MS nurse, consultant, and we would be more proactive in implementing these steps, I'm sure that it would change the whole data that we have available from the PRISMS study, which ages ago has been published, showing that the relapse rate is increased after postpartum. I think that will change over the time. What's your view, Vilija? Do you think it's going to, the whole data, having all these powerful medicine that we have available, I think that there is already a change in outcomes, in the research outcomes.
Yeah, absolutely. I think the more that we understand about how to use these medications safely in women, the more and more we see that there's less risk of postpartum relapse, rebound. So, for example, this using the strategy of using natalizumab up until the 32nd week and then restarting as soon as is practically possible means that women on this highly effective therapy have the same risk of a postpartum relapse rebound as women on low efficacy therapies. Whereas if women withdraw early, then their risk of a postpartum relapse rebound, so if they withdraw in the first trimester, is much higher. So we're already starting to, I suppose, create these algorithms that tell clinicians what the likely outcome is depending on when a woman stops taking a therapy. So they know, therefore, what the risk of relapse in pregnancy is or what the relapse postpartum is, so that clinicians can advise their patients. And of course, at the end of the day, it's the woman's own choice as to what she wants to do, but she can be strongly advised with all of this evidence from medical research telling us how we can minimize the risk of this disease activity. So I absolutely agree, I think. And we've seen that from the PRISM study. It used to be that 30% of women had a relapse rebound in the first 3 months. Now it's 14% because we're just understanding more and more. And so I'm very confident that with more research, we'll be able to reduce that number further again. There was a study recently published from our colleagues in Germany that suggested that about 30% of women are still having relapses, but this is within the first 6 months, not the first 3 months postpartum. And again, that was to do with different strategies that women might take when it comes to when they'd like to reinitiate their disease-modifying therapies, and also in relation to breastfeeding, but perhaps that can be our next topic.
Yes, Vilija. So the breastfeeding is something that I'm interested in. We highly encourage women to breastfeed their babies because their babies have to form and develop over the growing period of time, and immunity needs to be formed. And this is the most beautiful thing what women could offer to their babies. I know it's not for everyone. Not every woman can breastfeed, but I'm just thinking a little bit, and what is the science behind the scenes? Is the breastfeeding good enough to cover the disease activity postpartum? Or we see that actually the women who gone on the disease-modifying therapies as early as they gave birth, the reduction of the relapses is much more efficient in the group of patients who are on DMTs versus natural of the DMTs only breastfeeding. What is your view on this?
Yeah, so there's been a lot of research looking into this, and I think we still don't have a clear picture as to what the exact correct answer is, but we're getting more and more of an idea. So there were some studies that were published back in the early 2000s that were the first ones to really look at this idea of whether or not breastfeeding could prevent relapses postpartum. And these studies were really the first also to distinguish between what is exclusive breastfeeding and non-exclusive breastfeeding. And I think we really need to understand what those two concepts are before we go further. So if we talk about exclusive breastfeeding, here we're talking about women breastfeeding their babies every 3 to 4 hours, and the baby's receiving nothing but breast milk, except if, for example, they need some medication or something like this. And then non-exclusive breastfeeding refers to either the period of time when they're weaning off breast milk to start taking solids, or if they're being, I guess, alternatively breastfed and bottle fed, depending on, the baby's and the mother's needs. So exclusive breastfeeding every 3 to 4 hours for however many months, or non-exclusive breastfeeding where, again, you're either weaning or you're alternating with bottles. And so these studies looked at the impact of exclusive and non-exclusive breastfeeding on relapse risk postpartum. And again, there was a bit of bias there because we didn't necessarily have all of the same medications back then that are available now. So we have to think about perhaps the women that were included in those studies maybe not having quite the same level of disease activity, where now women with more highly active MS can safely have babies because their MS can be managed throughout that period. But there was an indication to suggest that women who breastfed, and particularly exclusively breastfed, had a reduced risk of a postpartum relapse. The idea behind that is that exclusive breastfeeding can suppress the menstrual cycle. It's called lactational amenorrhea. And so what the biology behind that is there's a few different ideas, but basically the hormones that are secreted during breastfeeding that then induces this state of lack of menstrual period. When women menstruate, they go through a cycle where there are periods in our menstrual cycles where we have more inflammatory activity in our bodies and less inflammatory activity. And that we actually need this, because if we do conceive, we actually need an inflammatory environment for the fertilized egg to be able to implant into the placenta. So, the reason why we need that inflammation is because inflammation encourages blood vessel growth, and we need those blood vessels to form to be able to support the growth of a fetus. So inflammation is actually a really, really important part of fetal development and implantation and successful pregnancies. And so the theory behind breastfeeding suppressing postpartum relapses is that you, by suppressing menstrual periods, you can actually suppress some of that natural inflammation that happens during that menstrual cycle. And so the theory at the moment is that this suppression of natural inflammation during the menstrual cycle might be sufficient to also suppress inflammation that may lead to a postpartum relapse. So that's some of the theoretical biology behind what we think is going on as to why exclusive breastfeeding might prevent postpartum relapse risk. But to the second part of your question, as to whether or not women who exclusively breastfeed are able to suppress that inflammatory activity as successfully as women who go on to use disease-modifying therapies. Again, our colleagues from Germany published this study just earlier this year, and it was actually quite groundbreaking, because even though there is evidence that exclusive breastfeeding can suppress inflammatory activity, what they actually showed was that women who breastfed exclusively still had a 38% chance of having a postpartum relapse, as opposed to women who reinitiated a disease-modifying therapy such as natalizumab. They had a risk of a postpartum relapse of 24%. So in other words, restarting a disease-modifying therapy reduced the risk of a postpartum relapse by 14%. So I think that's, quite significant. And so what this tells us is that if women had highly active disease before pregnancy, and we know that relapse activity is a predictor of both in pregnancy and postpartum relapse activity, then it's actually really important for women to restart a disease-modifying therapy as soon as possible after delivery as well, just to prevent relapses, because we know that some relapses can actually result in permanent disability if they're very severe, and we certainly don't want that for new mothers.
Wow, I learned a lot of things. So this is what it's like to talk to the biologists, immunologists, science-driven specialists, that you learn extra biology and understanding of the woman's body. It's super important, and I never thought about this inflammation that is required for the fetal development. We all our target is to suppress, to diminish the inflammation, the activity, but our body natural function, some level of the inflammation, I'm sure that is required for other functions in our body, that we can't be without inflammation. So all these cells are required to help us to function. So we don't need to be scared to have some level of the inflammation. And as you can see, the breastfeeding is preventative. perhaps if you had a highly active disease prior to the pregnancy or during the pregnancy, immediately starting the disease-modifying therapy after giving birth is probably the best choice, because you want to preserve your function, you want to look after your baby, so it's not going to be harmful if you prevent yourself getting into another severe relapse. But I think that leads to the other question: how much of the excretion of the DMTs we find in the breast milk is it safe to breastfeed if you are on disease modifying therapy? Maybe during the pregnancy you took you've been on the natalizumab, or after pregnancy, if you started disease modifying therapy, is it safe to still breastfeed if you are on disease modifying therapy? Vilija, what do you think?
Yeah, so there's some fantastic research on this. It's largely come from America, but also from Germany. So from Riley Bove's group at UCSF, as well as Kirsten Hellwig's group in Germany. And what they've actually done are some fantastic studies where they've actually asked women with MS who are using disease-modifying therapies and breastfeeding if they could pump some of their breast milk for analysis to actually see how much of these medications is getting into the breast milk, so that they could determine exactly what amount of it is transferring across and to determine whether or not that's safe. And so there's this magical phrase called the relative infant dose. And so that's how much the infant is getting of that medication through the breast milk as opposed to the mother. And so this is true in MS, but true for all drugs, irrespective of medical condition. And so there's this sort of magic number that says that the relative infant dose of medications should be less than 10% in the breast milk. And certainly that's been true so far for all of the monoclonal antibodies that have been looked at. So Tysabri and ocrelizumab. And so they've been shown to be safe to be used during breastfeeding. And that's because, again, these monoclonal antibodies, they're very large molecules. And so they just can't pass through into the breast milk very easily. And then it's thought that, you know, when our gut sees a protein, it digests it. And so it's the same here. So that if this large, protein, this monoclonal antibody is then ingested by the baby, then the enzymes that digest proteins in the gut will also be able to digest that. So the monoclonal antibody shouldn't actually have an effect on the infant itself. So there's more data for natalizumab than there is for ocrelizumab, just because of how long these therapies have been around for. But so far, it seems to be safe. This is true for mature breast milk. There's the one caveat here, which is colostrum. And it does appear that colostrum, so that very first milk that comes in the first day or two when women's milk comes in, that might contain slightly higher doses of the drug. Of course, it's highly unlikely that women would be breastfeeding on ocrelizumab anyway, because, trying to organize an infusion that quickly would be near on impossible. But certainly with natalizumab, it's much more realistic. Of course, again, most women, I think the earliest in one of our clinics that I'm aware of is that a woman got her natalizumab infusion the day after she delivered, but typically in Australia, at least, it's about a week later. So the colostrum is well and truly gone by then. But I don't know what it's like in the UK for you at the moment. But there are the new guidelines in Australia, for example, that I was really fascinated to learn about from one of our clinical nurses. And now women who are pregnant in Australia are actually being advised to pump and excrete colostrum before delivery, and to store this so that should the baby not be feeding properly to begin with, they can be fed that colostrum to beef up their body weight. And so perhaps, these sort of strategies might also circumvent any sort of transfer of disease-modifying therapies into the breast milk.
Amazing advice. I think it's very practical advice, and we should, I see the rationale. And then because you're covering the science and biology behind, I think this is what we should actually advise women to excrete their colostrum milk after they give a birth, in case there are some problems whether it's related to your MS or not related. Maybe it's a mechanical problem that's, feeding a baby after giving a birth might be stressful. Again, it's a good reason. I think it's a really practical advice that comes from one of the Australian MS nurses. So I think if you are elsewhere living in other country, and if you are a MS nurse listening to this podcast, this is really a tip to take, a message to take, and give that message, provide that in your clinics to potentially women who are just about to get pregnant or are pregnant. So amazing opportunity. I think, Vilija, you're bringing such a nice perspective from various different angles, looking at the biology, immunology, science, clinical experience, that you communicate with the clinical teams, and bringing that their sort of tips and tricks that we could implement and really change the practices in the world and help women to be healthier, to be more confident, planning the families, having babies. We have a lot of data now to support our decision-making processes that are informative. You're really going to be looked after before, during, and after postpartum. It's such a vulnerable and fragile moment for a majority of women. Giving a birth and going through all those hormone changes is mentally, emotionally, it's really affects a lot of women, and we have to be aware of the postpartum depression and mood swings and emotional impact. And then when you live with a chronic condition such as MS, make sure that you have a really nice connection network and help, that if you require to get some support, always go and do ask people to help you. So never stay on your own, in your own nutshell, thinking that things will pass. If you feel unwell, you always have to communicate that. And we covered a lot of grounds in terms of the disease-modifying therapies, breastfeeding, everything that is related to women's health and being pregnant or planning to be pregnant. But if you're still unsure, you always have to go and talk to your healthcare providers. We're not here giving you advice. We're not, that's not our intention. We are just enhancing the knowledge and understanding of the women's health, and in particular, living with MS and being pregnant or planning pregnancy is super important to get that information from the experts in the field. Myself, neurologist, and Vilija Jokubaitis, Associate Professor, who shared loads of expertise and knowledge for such a complex intersection of multiple sclerosis and pregnancy. And we hope this discussion has provided you with valuable insights and guidance on managing this challenging journey. It's never easy. Thank you very much, Vilija, for attending.
It's been an absolute pleasure. Thanks for having me.
Thank you, Vilija. To our listeners, thank you for joining us on this episode of the Be Well with MS podcast. If you found this information helpful, please consider subscribing. You just help me to enhance and produce more content as part of living with MS. I'm a neurologist, as you know, with a special interest in MS. I do run the Be Well with MS podcast, and you can link in and subscribe to the newsletter. Don't forget to share it with other people that it might benefit, and we will be back soon with more expert discussions on topics at the forefront of neurology and healthcare. Until next time, stay informed, stay healthy, and take care.